Okay, well, good morning, everyone. It's a pleasure to be here with you all. Thank you so much for joining. My name is Dr. Lauren Snedeker, and I am the director of the Aging and Health Certificate at Rutgers School of Social Work. Um, Also, a faculty affiliate member of the Hub for Aging Collaboration, which is our wonderful picture, as you can see up here, which is an amplifier of all things aging, a wonderful center under the School of Social Work, as it stands changing social context for aging, and there's information and little QR codes and tons of information that we can send following up from today if you'd like to get more connected with the hub and if you're not already connected to our Aging and Health Certificate program. So I'm going to go ahead and share my I'm already sharing. I'm going to advance. So again, welcome. Today's topic for our speaker series, which is what this event is part of. As the director of the Aging and Health Certificate, I'd love to have my friends and colleagues come back and alum come back and share a little bit about their work and their expertise. It's timely given changes that are happening on a federal level. So we're going to be talking about H.R.1, and that's just a little image of our flyer where we'll talk down policy and break down, specific points and things to be mindful of as we continue on in our practice as social workers, whether we're doing direct practice, meso practice, macro practice. It's important and relevant across all different spaces and places, working with older adults, individuals with chronic health, individuals who are disabled. It all is extremely important and mindful to keep mindful about. So I'll do just a brief introduction of all of our wonderful speakers, our colleagues and friends and alum from the Aging and Health Certificate Program that will be speaking today. First, we have Galila Selassie, who is a senior attorney from Justice and Aging. Next, we'll have Brianna Payton Williams, who's a wonderful alum, a TALB fellow, and presently the senior program manager of policy and advocacy at Trenton Health Team. And presenters, if you don't mind waving, that would be great. We have Monique Turner, who's the supervisor of investigations for our long-term care ombudsman's office for the state of New Jersey, and EJ Vizzi, who's the director of senior programs at the Brightside Family and also a fantastic alum of the Aging and Health Certificate program. So thank you to all of our presenters. Thank you to everyone being here today. I appreciate you. And I'm going to go ahead and advance and see if I can spotlight our first speaker for this morning. Goodness, I teach online all the time, but I look like a rookie right now. I apologize. Give me 1 second. I'd like to spotlight our first speaker, Galila. Thank you so much.
Of
I
course.
hope that worked. Okay, great. Thank you.
Yeah, absolutely. Thank you so much for having me. I'm always happy to talk about all things health policy. As I mentioned, I'm Galila Selassie. I'm a senior attorney at Justice and Aging based in the DC area, but we do a lot of work in New Jersey, and we work with the TALB Foundation on specifically on some New Jersey issues with some legal aid advocates and disability advocates in the state. So not too unfamiliar. And if we can advance, so Justice and Aging is a nonprofit organization. We're based out of DC and California, and we use the power of law to fight senior poverty since 1972. I work on the healthcare side. We also have an economic security side. We do a lot of elder rights work, litigation, and economic security and housing as well for low-income older adults. And then we're primarily focused on older adults who are marginalized from society because of their race, gender identity, orientation, role, status, etc. Next slide. And you can advance just one more time. So what I'm going to do is just give a quick overview about HR1, or quote unquote One Big Beautiful Bill Act, officially named HR1. And then I think the other folks are going to go into a little bit more detail on the impacts for social workers in the state and individuals in the states. So there's a lot in HR1, a lot. But I think in terms of the healthcare side, the big takeaways that are going to have the biggest direct impact on beneficiaries are the work requirements, um, increased renewal periods or increased redeterminations, huge and significant impacts on for immigrants who have lawfully present statuses who are now going to have a harder time getting Medicaid as well as Medicare and ACA coverage. There's now mandatory cost sharing in Medicaid, and then there's a reduced retroactive period. Next slide. And so to start with the Medicaid work requirements, this is the big doozy of the legislation. Beginning by January 2027, although unfortunately some states are implementing it sooner, all Medicaid expansion enrollees must work at least 80 hours a month, or rather, they must engage in a community activity, qualified community activity for 80 hours a month. That's typically going to be a paid employment. It can also be unpaid volunteering, schooling, or job training. Crucially, this only applies to people who are between the ages of 19 and 64, and only the expansion population, or a few states that have waivers that provide sort of like expansion Medicaid, but not exactly expansion Medicaid. Critically, this does not include people who are eligible for Medicare or dually eligible individuals, and it doesn't include anybody who's receiving Medicaid through a disability pathway or an age, blind, and disabled pathway. That's what the ABD is. So this is just the Medicaid expansion population. One other big factor is that they must show compliance with work requirements before being approved for Medicaid. So if I were to apply for Medicaid in February, I would have to show that I was working and meeting these requirements in January, or that I meet one of the exemptions. And then the exemptions for that expansion population apply for individuals. There's a lot of them, but the big takeaways are the biggest groups are for quote unquote medically frail. That's the language in the statute, which is why I'm quoting it, but it's obviously a terrible wording. But that typically just means people with disabilities. And then caregivers of disabled individuals, older adults, or parents of children under 13. Those are the big categories of people who are going to be eligible for individual exemptions. There's a few other individual exemptions for former foster care youth, for the recently incarcerated, and things like that. But these ones are going to be the ones that are going to have a lot of, we've seen in when states have implemented work requirements in the past, they have a lot of difficulty trying to sort of prove their exemption status and often end up with a lot more paperwork. And it's going to be the bigger population of Medicaid expansion enrollees are going to fit under these two categories of the exemptions, the medically frail / disabled and the caregivers. And then another really last minute addition to the legislation that's especially cruel is this lockout provision. So anybody who is subject to work requirements but fail to meet the 80 hour a month requirement are now not only going to lose their Medicaid, but they are now going to be ineligible for marketplace tax credits. So it's a sort of lockout provision. The idea is that it's worded in a way where by not completing the Medicaid work requirements, they're choosing to decline minimal essential coverage. And under the ACA, if you have minimum essential coverage, then you can't qualify for tax credits. So very, very cruel. And that's what we see will lead to a significant amount of people being uninsured. There's a lot of people who are within that 100% to 138% of the federal poverty level range, where they kind of could fit in either or bucket between Medicaid expansion or ACA tax credits. And now they're going to be barred from both, which is really troubling. Next slide. And so why are work requirements unnecessary? First of all, most people on Medicaid are working or meet an exemption. KFF did a study early last year, and they found that 64% of Medicaid enrollees under 65 worked at least 20 hours a week, many of them working full-time or close to full-time. And I have a link to that stat there. And then of the remaining, what is that, almost 30% that aren't working, 12% are caregivers, 10% are disabled or have a chronic condition, and 7% are in school. So if you add the 64% of Medicaid enrollees who are working, along with that additional 28%, what you're going to find is that 92% of Medicaid enrollees already meet the work requirements or an exemption. And yet, when the Congressional Budget Office was looking over the legislation and seeing where there are going to be significant savings, and coverage losses, this is the biggest pile. This is about 300 billion of the 900 billion dollars in cuts is from the Medicaid work requirements. And it's going to be not because that tiny 8% that isn't working and isn't exempt is going to lead to hundreds of billions of dollars in savings. It's going to be because one portion of that 92% are going to be improperly terminated because states are either going to define um, uh, this very, very narrowly, or there's going to be problems with the reporting. And we've seen that in the past in Arkansas and Georgia, where qualified people are kicked off due to technical errors, administrative issues, really burdensome exemption processes, and so on. So as you can tell, I'm not a fan. So we can move on to the next slide. I'm not going to read all of this, but this is just an example of a client story. I used to practice in a state that before they had Medicaid expansion. And so in order to get Medicaid, they basically had to prove their disability because the only way to get Medicaid at that point was a disability pathway. The same thing is going to be happening in a way with these disability-based exemptions to get on expansion Medicaid. You basically have to prove you're disabled. And to prove you're disabled means you need health care. You need medical records from a doctor or forms filled out from your physician or things like that. And in order to go to the doctor and to get those medical records, you need insurance. So it's this impossible catch-22 that we're going to be seeing evidenced by this gentleman that I helped who was applying for Medicaid. In that case, he was applying for a disability-based Medicaid, but the same exact situation would apply where if he's trying, he doesn't meet a work requirement due to his disability, and now is now also prevented from getting marketplace subsidies, so he's uninsured. He's relying on his hospital sliding scale program, so he gets discounted care, but it's still a lot of money for him. About $50 for an office visit and $60 for his diabetes medication. As a result, he cuts back on his medication. He rations them out. He doesn't go to the doctor as often. And then because of that, there's the state is saying, well, we need you to go to the doctor to fill out these forms, to submit these medical records, to go through this period so that you can qualify for an exemption. And he's saying, I don't have hundreds of dollars to do all that. So unfortunately, he's denied Medicaid. He continues to ration out his meds and not get the care he needs. And eventually he gets to a point where he's hospitalized for gangrene and permanent vision loss. So now he is fully determined disabled. But all of that could have been avoided had he not had to go through such a difficult process to prove he is disabled. Next slide. Another big problem is the more frequent renewal periods or redetermination periods, which will absolutely lead to more procedural terminations. So beginning in 2027, all Medicaid expansion enrollees will have to submit all their renewal paperwork every 6 months instead of every year. States are supposed to engage in these ex parte reviews, meaning they're supposed to look at existing data sources to determine eligibility so that minimizes the amount of paperwork and forms individuals have to fill out. But these data systems can be inaccurate, and there may not be an opportunity to for individuals to resolve them. And then one of the biggest hurdles with more frequent renewal periods that we saw during the Medicaid unwinding period after the COVID-19 public health emergency ended is that we almost always will see a greater likelihood of people being terminated for procedural reasons. That means they're not ineligible. They didn't lose their Medicaid because they're no longer eligible, but because the paperwork got lost, the forms are completed incorrectly, there were some delays in processing the forms on the state side, they changed their address, a million reasons that has nothing to do with a person's actual eligibility. And so this is, again, where a lot of the savings are going to come. It's not because millions of people are going to suddenly not be eligible for Medicaid after 6 months. It's going to be because maybe a small percentage of them might not be eligible, but there's going to be significant problems with the just procedural process of getting those renewals done. And then next slide. And then, as we've seen from pretty much every aspect of our lives, there's this really awful hardship on immigrants needing to access Medicaid, Medicare, and ACA coverage. One thing that people might not realize is that Medicaid has had very strict immigration restrictions since 1996. In the resources section, I linked to the National Immigration Law Center that does a very good job of explaining it. But it is incredibly, incredibly complicated, the eligibility rules for Medicaid for immigrants. There's a distinction between qualified immigrants like refugees, asylees, and lawful permanent residents, LPRs, who are people with their green cards, and lawfully present non-qualified immigrants, who are also people with legal status, but who have other types of visas like work visas, student visas, or temporary protected status. There's also a 5-year bar for green card holders, lawful permanent residents. So even if you've in this country lawfully, you have your green card, you're a permanent resident, you qualify for Medicaid, too bad. You can't get it for 5 years no matter what. For most adults, the rules are a little bit different for children. And then there's some small category of immigrants who can qualify for emergency Medicaid, but that's pretty limited. And then Medicare and ACA coverage historically has been much less restrictive. For the most part, you just have to be lawfully present. DACA recipients may not qualify for subsidies, but otherwise, most lawfully present people are. And same with Medicare. If you're lawfully present but meet some residency requirements, as in you've been in the States for a certain amount of years, you also get Medicare. So it's historically been really complicated for Medicaid, much easier for Medicare and ACA. Next slide. Now that's about to change. So Medicaid is now in this position where most non-lawful permanent residents are now barred from Medicaid. And that's particularly those who are on those humanitarian programs like refugees and asylees. And then Medicare and ACA saw the biggest restrictions where now coverage is going to be limited to lawful permanent residents. And then these other two very, very small categories of people were in our Cuban and Haitian entrants under a family reunification program. So not just Cuban Haitian citizens, but people who are in the United States under this very, very specific visa program, and people residing under COFA, which is just citizens of a very few states in the South Pacific. So again, millions of people will be losing coverage who are lawfully present, who are still paying their Medicare taxes, and those went into effect pretty quickly. Next slide. So now the other big bit is that last bit that I'm going to talk about is the cost sharing and the reduced retroactive period. So now for the first time, Medicaid is imposing mandatory cost sharing, which means individuals who are on Medicaid who are very, very low income will now have to pay co-pays for many of their services. Fortunately, the statute does exempt certain services. So that'd be primary care, emergency room visits, mental health or behavioral health, and substance use disorder care, and then services provided by certain practices like federally qualified health clinics and the behavioral health and rural health clinics. But specialty care and other types of care that isn't considered primary care will be subject to cost sharing. The copays can be up to $35, which is a lot, again, for somebody who's barely over the federal poverty level. And then again, this is only for the Medicaid expansion population. The statute does cap it at 5% of the household income. So all the copays within the year, there's sort of a little bit of an out-of-pocket maximum. But we haven't seen much guidance yet on how that looks if you have multiple people on multiple Medicaid programs and such. So we're waiting to see how that's going to be applied. And then the other bit is the reduced retroactive period. So normally when a Medicaid application is submitted, somebody can get, if were eligible, then they can get their Medicaid coverage covered for the 3 months prior to the application being submitted. So if I submitted an application in March, then I can have any healthcare services in February, January, and December covered, as long as I was eligible for those months. Now that period is going to be reduced to just 1 month. for Medicaid expansion populations and 2 months for all other Medicaid populations. And the biggest thing here is just noting that this applies to the period before the application is submitted, not the application processing time. So if I submit an application in March, but the state is taking 5 months to approve it and it's not approved until August, I'm still going to be covered until at least March if I was eligible during that period. And then if I'm on expansion, I'd only get February covered as opposed to going back to December. And then next slide. So this is the impact on enrollees. About 10 million people will lose Medicaid, 15 million more will be uninsured. I've talked about all the disincentives this creates in terms of the cost sharing and the increased paperwork and problems this will pose for individuals. And then as we know, when people have reduced access to healthcare, their health outcomes get worse, they lose their coverage, and that creates significant greater financial hardship for hospitals. There's a massive chilling effect on immigrants right now in every aspect of our society, but especially in those needing healthcare. And because of the complexity and the rhetoric that's going on, even eligible people are not going to be signing up for coverage, which again just leads to much worse health outcomes. And then there's likely going to be indirect cuts to other services. So we've seen in Georgia when they implemented work requirements that everybody had significantly longer periods of time where their Medicaid was taking longer to be processed because so many resources were going to enforcing the work requirements. And then there's other provisions in the law that actually cuts Medicaid funding through this mechanism called provider taxes. I don't want to go into it because it's a little bit wonky, but the point is that many states will be getting less funding from the federal government for their Medicaid programs, which is going to force states to decide whether to keep optional programs like Medicaid home and community-based services, which keeps people out of institutions. And then for the next slide, just the role of advocates here, including social workers and disability advocates and all others, is making sure that you are really raising awareness, education, and communication. There's a lot of disinformation about H.R.1 and about who is on Medicaid. The biggest one was that only people who are 26, apparently there's an epidemic of 26-year-olds playing video games all day, not working, just using up Medicaid. And that is clearly not what we've seen the majority of Medicaid enrollees are. Most are working or disabled or caregiving or in school. And these rules are really, really hurting people at the expense of just creating this, fake 26-year-old hypothetical or the idea that only undocumented immigrants are going to be affected. That's just not true. A big one is never assume your state or federal government has it right when they're making decisions about how they implement this. There's a lot of overworked Medicaid workers who might mean well, but are burdened and providing the wrong information. And then there's almost always going to be a lot of technological and technical errors due to contractors. And even though New Jersey is a very Medicaid friendly state, I had a former boss who always told me never underestimate a political leader's ability to screw over poor people. Unfortunately, when there's budget cuts, when there's pressure, or the political winds are going a particular way, anybody's really capable of making some really difficult decisions that harm the most indigent population. So New Jersey's, not Mississippi and is in a lot better place in a lot of ways, but everybody really has to work hard to put the feet to the fire. And with that, the biggest thing is collaboration. People are going to be losing their coverage. They're going to be having questions. So making sure there's a robust system in place of referrals, of getting information is really critical. And folks are always welcome to reach out to Justice and Aging or anybody else for help. The next slide is just a timeline that I have a little hard to see on here, but folks are welcome to use it later. And then the last slide are a bunch of resources for folks, including one of our budget reconciliation tools includes that timeline in a little bit more detail. So you're welcome to take a look at that. So thank you, everybody. I will pass it over to, I don't know who. Oh, Brianna.
To Brianna, Galila, thank you so much. I took so many notes and thank you so much. I know you're a little under the weather, so we especially appreciate you being here and providing such a a digestible breakdown of things that we can expect and understand and sort of use our social work thinking caps to think about our next steps, whether we're in current practice and we see these things happening in real time, or for my students, feeling a bit more empowered with information, knowing that we can digest and understand and do the best that we can for those that we work with. So thank you so much. I really, really appreciate it. I'm gonna go ahead and uh, spotlight our next speaker who's on the screen now, Brianna Patton Williams. Give me 1 second. I'm so sorry that I'm just like a little slow with my tech today. Um,
Lauren,
oh, did I?
I got it.
Oh, Dr. Greenfield, thank you so much. I really appreciate you. Okay, Brianna, you are ready to start whenever. Thank you so much, Galila, as well. And we'll have time for questions for all of our panelists at the end of our talk today.
Great. Thank you, Dr. Lauren. And hi, everyone. I'm Brianna Payton Williams. I'm a senior program manager of policy and advocacy at Trenton Health Team, but also a former MSW student. I was in the Aging and Health program. I graduated back in 2024, so not too long ago that I was in your shoes. So I'm really excited to be back here to talk also about Medicaid and as a social worker, what I've been seeing as some of the direct impacts within the Trenton community, but across central New Jersey. Next slide. So, Trenton Health Team, we are a local organization based in Trenton. Our work is focused on improving the health and wellness of members, not just in Trenton, but I'm now proud to say across the central New Jersey area. Our work focuses on a number of social issues and topic areas and priorities, including Medicaid support, which I'll be talking about today. We also focus on maternal health for birthing people and infant. We also focus on harm reduction, as well as food insecurity, housing, community development. So we touch on a number of issues when thinking about the social determinants of health, which are the things that really impact us on the day to day when thinking about food, housing, what resources you have in the community. But more specifically, and we'll go on to the next slide, I'll be focusing on our Medicaid support for Trenton Health Team and our regional health hubs. And that's a specific initiative within our Medicaid support. I always like to think of the regional health hubs, and I'm going to say RHH just to save my breath. I think of the RHHs as a bridge between the community, specifically Medicaid members. That is the focus of our work through RHH and serving as that bridge between the government, which we know there's a lot of red tape, there's a lot of bureaucracy, and often what the government is thinking up top is not always what's happening in the community. So at Trenton Health Team, our work is really focused on ensuring that for anyone who's eligible for Medicaid benefits and has those benefits is actually able to access them and utilize the benefits. And so I know we previously spoke a lot about what are some of those direct impacts when thinking about the H.R.1 or the One Beautiful Bill or whichever title you want to use. We've really been seeing a lot of that direct impacts when thinking about folks in their day to day. And through our regional health hub, we really work closely with the state Medicaid office, as well as others within agencies, others working on the ground, community-based organizations, to really understand what does that experience look like for Medicaid members. For myself and my work, that involves talking directly to Medicaid members on the day-to-day, whether that's our community health workers making phone calls directly to Medicaid members to ensure that they are aware that they're getting something in the mail, that they need to renew their coverage and send that packet back, to holding focus groups and interviews with Medicaid members to really understand what are the nuances of what it means to utilize your benefits. And I think now doing this work and having a social work background, I've seen that a lot of folks are not aware of the nuances of what's the lived experience to be a Medicaid member and the disparities and the challenges. And I know we spoke a lot about that when thinking about the provisions, but a lot of these impacts and disparities have happened well before the Medicaid provisions in the H.R.1 bill. And I've been fortunate to be able to see some of that, whether that's actually having the literacy to understand when that packet is being sent to your home, what to actually do with it. There's the language accessibility of knowing that for majority of Medicaid members, when that packet is mailed to their home, it's automatically sent in English. It's often not sent in their preferred language unless it was noted. But if you're getting something in English, you won't know how to go and request it in your preferred language. Or just the accessibility of if additional information is needed for your application, do you have the literacy to know how to upload it into the portal? Or for some, they have to go directly to the Board of Social Services. Do you have transportation to get there, right? And so there's a lot of nuances when thinking about the provisions, but also just the day-to-day experience of what it means to be a Medicaid member. And so we talked a lot about the provisions, but it's also important to remember what is the usual experience for a Medicaid member when thinking about the barriers and the disparities. For majority of the Medicaid members that I work with on the day-to-day, access to a traditional primary care physician is not as accessible for someone like myself who has private insurance through my employer. For a lot of Medicaid members, simply finding a primary care provider is actually a challenge. There are many doctors here in Trenton and just across New Jersey where they're not accepting Medicaid simply because of the reimbursement rates. Or for people who are looking for a specialist, whether that's a dentist, for the average Medicaid member, a number of benefits are not covered for dental care. And so finding a dentist, whether that's for your child to get braces, easier said than done. Finding a dentist, finding a hearing aid doctor for here in Trenton, a lot of the members that I speak to, their closest hearing aid doctor is in Philadelphia. And if you don't have a car, you don't have the time to take off from work, what seems as something so simple for me to be able to go to my doctor who's maybe 5, 10 miles away is a true barrier when thinking about simple access to care. And so I put that to keep front of mind of for myself, I'm a social worker. And while I'm not a clinical social worker, so much of my work is community based. And so I always say front of mind of regardless of what MSW student you are, whether you're clinical, you're community based, or macro, for me, I was a MAP student focused on aging and health. These policies will directly impact Medicaid members, whether you are reading a piece of legislation or you're working with them directly. And, when I first was stepping into this field, I thought, how am I going to be working directly with people if I'm doing policy work? And it's happening right before our eyes. And so I know we have a mix of folks on this call, but I just kind of want to humanize what does that experience actually look like for Medicaid members, because I think we often take for granted what it truly means to have access to quality healthcare. So with that, I'm going to move on to the next slide. So I want to dive a little bit deeper into understanding what does the Medicaid population look like here in New Jersey. So within New Jersey, we have the NJ Family Care Program, which essentially is the acronym for Medicaid, but that is the state-run program for Medicaid coverage. So taking a bit of a deeper dive, looking at the New Jersey Medicaid population, we talked a lot about kind of what do those provisions look like on a federal level, but it's important to understand what does that demographic look like here in New Jersey. Now, within Jersey, as of August of 2025, but I know things might have changed as of now in January 2026, from the Department of Human Services, as of June of 2025, the Medicaid population was around 1.85 million. And that's about 20% of New Jersey residents, which is, I'd say, a pretty significant portion. And we know when thinking about the H.R.1 bill, we know a majority of older adults over the age of 65 may not be directly impacted by some of these Medicaid provisions, but I know colleagues on this call will talk about what are some of the nuances outside of Medicaid, but thinking about nursing homes and some of the other access of care that will directly impact Medicaid members. But I think it's important to go a little bit deeper of understanding who are the individuals in New Jersey specifically that will be impacted by the Medicaid provisions and some of the other provisions as well. So we know of the Medicaid population, the folks that are really being impacted by these provisions when thinking about the shift of the annual renewal process from 12 months to 6 months, thinking about the workplace requirements, that's about 30% of the current Medicaid population. And as mentioned before, it's folks between the ages of 19 and 65 or 64, excuse me. But it's important to remember, as we talked about the nuances of what it means to be a Medicaid member, I like to point out a couple of examples where an older adult may be duly enrolled and maybe is a part of that other bracket of the aging, blind, and disabled, but still is impacted by the expansion the expansion adult population. And recently I had an older adult who was Medicaid enrolled, but also had a grandson that she takes care of who is 10 years old, who is also Medicaid enrolled. And so you might also have scenarios where you're thinking, I'm working with someone who's maybe 75 years old, they're duly enrolled, they may not be directly impacted by the workplace requirements, but they still might have to do a Medicaid renewal application for someone in their family. They might need to help their grandson with doing that application, as I spoke to with a lady just a few weeks ago that lives at the Trenton Housing Authority. And so while there may be older adults who aren't a part of the demographic demographic that don't have to do the application, they still are someone that's going to be directly impacted, whether they're a caregiver for a family member or a grandson or a child, or for a lot of folks here in Trenton, things are word of mouth. So education is power. It's still important that folks understand and know what are the things that I need to share with my family and friends as we're thinking about what these changes actually look like. And so I always say it's important that while you may not work directly with someone that's impacted, in some way, shape, or form, there is a trickling effect and a ripple effect of that information still needing to be disseminated and them still understanding what are those impacts. Because here in Trenton, the word of mouth has created disinformation, or for some folks, the confusion of, I heard you're supposed to get this packet, but I don't know who I'm supposed to send it to, or my county of supervision is telling me one thing, but I'm hearing another. So it's really important to understand that older adults, for a majority of them, they may not be impacted by these Medicaid provisions, but there's still the rippling effect of ensuring that they still understand what this process means for them. And so going on to the next slide. So we previously spoke a bit about what those Medicaid provisions look like. I won't go into kind of the nuances of it because I think Aaliyah gave such a great presentation initially of just what do these impacts look like. But I think just going back to what we spoke about with the changes in the annual renewal process from 12 months to 6 months. And for what I've been seeing on the ground is we're really starting to see those rippling effects of folks not wanting to complete the renewal packet because the fear of I'm not going to be eligible. So what's the point of even doing the application? And so I tell people that while these provisions aren't really going into effect until 2027, we're already seeing the impacts of folks not wanting to send their packet back, or when we give phone calls or text messages, folks not wanting to respond out of fear, out of retaliation, even if they are a US citizen, but they look a certain way as a Black and Brown person. So we're already seeing the impacts and the rippling effect of these provisions. While they haven't gone into effect yet, the fear already exists, like we've been mentioning before. I've seen in my work when thinking about even folks just completing the traditional 12-month annual renewal process, people are fearful to leave their homes and to send in the application to the Board of Social Services, even though they need that in-person assistance because they don't want to call on the phone, right? So we're already seeing the rippling effects of folks not wanting to leave their home. Here in Trenton, there has been a high presence of ICE agents. And so for me, when trying to meet Medicaid members where they are, of just understanding what's their experience as an older adult, for birthing people who are using the reproductive health services, we're already seeing those rippling effects of folks not wanting to leave. And so I'll talk a bit about what are some of the tips that I'm kind of recommending as of what it means to meet people where they are. But my biggest kind of headline with what I've been seeing so far is the provisions haven't started, but the rippling effects are already taking place. And it's really important for us as social workers to really try to meet people where they are while understanding the nuances and the fear that's already starting to kind of percolate across the community and across New Jersey. And so going on to the next slide, and then we'll have to unfortunately click about 3 times, Lauren. This happened to us before. And so just some recommendations of what I think is helpful and what's been helpful for me and my work when engaging with the Medicaid population is minimizing the added burden for Medicaid members. We are living in a really intense time where the average task for someone might be a bit more challenging. And so previously, I would say in my work of, oh, come to my office, I'll help you with the application, or come into the office so we can talk about kind of gathering some feedback of what has been your experience with using dental care as a Medicaid member, or what has it been being a birthing person trying to give birth in a hospital. The fear of someone coming to our parking lot because there has been an ICE agent, that means I've had to think a little bit differently about what does that mean to minimize the burden for Medicaid members, but to still do my job. And the end of the day, my job is to gather the feedback, to bridge that gap, and to share that back with the Medicaid state agencies so they can improve that program. So minimizing the burden for me as a social worker has been finding a place that's undisclosed or disclosed that's a safe location. So I've started to meet Medicaid members at libraries, or maybe it's at a coffee shop that's comfortable to them. Or for you as a social worker, if you're clinical or macro, that means if you're comfortable, if or if it's allowed within policy, meeting them at their home, or just finding a safe location that minimizes that burden. Or while it seems simple, of just is there a language translation barrier where there needs to be that additional support? If we're going to meet them in person, are our materials translated and not just brought in English? I know here in Trenton, there's been an uptick of the Haitian Creole population. And so over the past 2 years, initially my materials for Medicaid have traditionally been in English and Spanish. And we had to pivot real fast to say, okay, there's an uptick of a need. I was at a school down the street in Trenton. A mom came to me speaking in Haitian Creole. And I said, okay, I'm noticing a theme where people are speaking Haitian Creole. We have to pivot because if this is about meeting people where they are, getting their children enrolled, we have to really learn where to meet people where they are. And kind of going into that second bullet point of just planning for the member experience to change over time. We've seen the experiences change over time well before the pandemic, but we're really learning as social workers that we have to be quick on our feet, but also realizing kind of coming back to what does it really mean to meet people where they are so you can continue to do your job, whether that's through case management, whether that's through talk therapy, or for me, when talking about policy work, of understanding what does it mean to share that experience from a policy level, whether it's legislative, regulatory, or with the state agency, really planning for the member experience to evolve and what does it mean to adapt as a social worker and to pull in some of those additional resources where needed that might go beyond your expertise. And the last that I really want to highlight is leveraging community-based organizations and partnerships for member outreach. I always say my work does not operate in a bubble. Even on the policy level, I can't do what I do unless I know what's happening on the ground. And I've seen the power of using community-based organizations who are often a source of trust when thinking about the older adult population, whether that's connecting with an older adult center where an older person is going on a regular basis, whether it be for food, for case management, for housing assistance, or for many, for immigrant populations, they're receiving social services and support. So, really leveraging the community and the network that you have, because I know for Trenton, sometimes I'll pull into a space, and while I may be a social worker, I am a Black woman, I have my lived experience. If they don't know who I am, it doesn't matter what I look like and how I move. It's really important to leverage the trusted sources that are within your community so you can continue to build that rapport. Because one thing I've learned from Medicaid members who are often talking to me honestly and transparently is if they don't have that level of trust, they don't want to go that extra step to get the level of support that they need, whether that's housing, whether that's food, whether that's the simple completing of an application and wanting to come back to talk to that social worker. So leveraging the partnerships that you have and really understanding what does it mean to tap into that network within a community to continue to meet the needs. And so I really just wanted to share what has that experience looked like for me. I had to pivot fly because Galia, you took some of my talking points. I'm not mad about it. I'm talking a bit about the provision. So, but I really wanted to talk more about what has that kind of experience looked like for me as a social worker and how I've been seeing what does it mean to bridge from the macro side, working from policy and connecting it down to the clinical and vice versa. Because you'll see that as you enter the workforce and even through your field placements. And so that's kind of my advice for you all. But I'll pass it over back to Lauren and colleagues who will talk a bit more about the older adults in the nursing homes.
Brianna, thank you so, so much. I really appreciate the other and very important factors that you've brought into your presentation that are very significant and critical to understand as well. Sort of, we're evolving through our talk today with like good concrete and digestible facts, as well as the living experience and recognizing other factors that impact the member experience, which as social workers, for most of us on the call as social workers, we very much need to understand and pay attention to this as well. Not only the sort of logistical process, but also what it feels like to go through that logistical process and recognizing power differentials and everything that we talk about in our coursework and that you're learning about, as Brianna has really highlighted in their talk. So thank you so, so much. We're going to, again, we're going to have questions for all our wonderful panel presenters at the end. So we're going to move right on forward to Monique. I'm sorry, I lost my here we go. Thank you so much. I lost my mouse. And we have Monique Turno, who's the Supervisor of Investigations from our Long-Term Care Ombudsman's Office of New Jersey. Thank you so much.
Hello, everyone. Thank you so much for having me. Like you said, I'm the Supervisor of Investigations for the Long-Term Care Ombudsman's Office. I'm a social worker and I have my license in Nursing Home Administration. The Long-Term Care Ombudsman's Office is a resident advocacy group We advocate for residents who live in the nursing home, independent living, assisted living, group homes, adult medical daycare centers, and developmental centers. So today I'm here to talk to you about how this bill is going to affect residents who live in the nursing home. So you can go to the slide. Thank you. Okay, so there's two types of residents who live in the nursing home. There's the long-term care resident and the short-term care resident. The long-term care resident is a resident who lives there. They're going to live here for the rest of their life. This is their home. They require 24-hour skilled nursing as well as aides to assist them with activities of daily living like dressing, bathing, toileting, and sometimes even eating. The short-term care resident is a resident who's there for a short period of time. These residents live in the community, experienced some type of acute illness, and went to the hospital. And when it was time for them to leave the hospital, they're not quite ready, so they go into the facility for some rehabilitation and some strengthening. Some examples could be if someone had a hip fracture, maybe recovery after heart surgery, or needing extensive wound care. These residents will return to the community when their rehab is complete, usually needing some additional services in their home to continue their recovery. The payer sources for the long-term care resident can be private pay, which is between $14,000 to $15,000 a month, which is absolutely crazy, or Medicaid. The cost is really expensive, so most residents are covered by Medicaid that live in the nursing home. Either they come in as straight Medicaid or they quickly spend that money down and have to make Medicaid application. So you can imagine this bill is going to greatly affect this population. The payer source for the short-term care resident is usually Medicare or a managed insurance company. We don't have to switch the slide yet. So the short-term care resident, Medicare or managed insurance company is paying for them. Where this bill is going to affect them is when they get ready to go home. A lot of times they'll need some additional services to continue their recovery at home, like home health aides, durable medical equipment, wheelchair ramps, things like that. Okay, next slide. H.R.1 is going to affect both types of residents in different ways. The private pay long-term care resident obviously is not going to be able to keep paying that amount per month. So they're going to need to make Medicaid application. Usually in the nursing home, families, residents, and the facility actually look towards the social worker to provide guidance and resources to be able to make that application. The application can take months to process, as we kind of talked about earlier. The Medicaid can look back 5 years. They can ask the resident and the families for 5 years worth of bank statements, 5 years if they gave any big gifts and they need to get receipts for that, if they sold a home, if they sold a car. They're basically just trying to make sure that this resident is financially eligible for Medicaid. This new bill is going to, again, like we talked about, only go retroactive for 1 month. So that means if a resident runs out of money in June and makes Medicaid application and it takes 3 months for it to go through, Medicaid is only going to go back 1 month. So that leaves that resident vulnerable for June, July, and August with no payer source. And facilities don't like that, obviously, and it can jeopardize this resident to have to be discharged. The Medicaid resident who's living there under Medicaid already has to do a redetermination. Right now, that redetermination is once a year. This bill is going to make that redetermination to be done twice a year. So this is pretty cumbersome for the resident and the family. It's a lot of paperwork to fill out. If they miss the time frame, they could lose their Medicaid for different months. And again, leaving these unpaid accumulative balances where these residents could be discharged. So the impact of that for the social worker who's working in the nursing home is obviously these facilities require payment for the resident to live there. A lot of times they're looking to the social worker. What's going on with this resident? When are they going to start paying? Where are they at in the Medicaid process? And sometimes they might pressure the social worker to try to find alternate placement. Next slide. Some other effects could be that there's going to be an increase in institutionalized residents. As home and community-based services are cut, this could cause more residents who are living in the community safely with these services be pushed back into the nursing home. So right now, social workers already have a pretty high caseload. So if you have more people coming in there, it's really going to stress the time per resident you can spend doing case management because you have so many residents there. Also, the facilities are going to be receiving less Medicaid money. So when that happens, they usually look to cut services in the nursing home to make up the difference. So they'll do things like using cheaper linen, lesser quality activities where the residents used to be able to go out and have entertainment in. Now they're sitting around playing bingo. They'll use lesser quality food. And the biggest thing that they do is cut staffing. They'll try to use the minimum amount of people to take care of these residents, and they won't replace call outs when people call out. So for the social worker, this, it's a decrease in the residents of quality of life as everything is kind of changing and they're not doing the things that they used to do, and an increase in the complaints and grievances. The social worker in the nursing home is the person who the families and residents go to when they have issues and complaints. So, there's actually a grievance process in the nursing home where a resident will fill out if they're having an issue, and they fill out a form, hand it into the social worker, and it's up to the social worker to keep a log of that and also track the resolve of that. So, with the nursing home cutting all these things, it's just going to increase the complaints and the things that the social worker will have to deal with. This bill is also going to affect the short-term care resident, because when these residents are finished their rehab, they're going to go back out to home and go back out into the community, and they're going to need some services to continue their recovery at their home, which the home and community-based cuts that are happening, it's going to be difficult to find things like housing, home health care, and other needed services like Meals on Wheels and things like that. So for the social worker, it's going to complicate discharge planning for the residents who are returning home, and it's also going to increase the risk of unsafe discharges. So what can you do? One of the things you can do is call our office. Our office investigates abuse, neglect, and exploitation. Right now, we are seeing an increase in residents who are being involuntary discharged for non-payment. You can go to there you go. That residents are being discharged for involuntary payment. You can call our office. We can go advocate for that resident to make sure that they aren't discharged and they get to stay in their home. We also investigate complaints of things like poor food quality, lack of activities, if there's not enough staff. Pretty much anything that goes on in the nursing home, you can call our office and we can go out and investigate. You can give our number to residents and families. And also, if you're a social worker in a nursing home, you can call us yourself and you can remain anonymous. We don't have to say who called. You can also reach out to your community. A lot of, the counties and states have additional resources that you can tap into. I know Google is all of our best friends, so you can kind of see what additional resources you can use to help. I know my county has a transportation service for the elderly that, we could use if someone was going home. And lastly, just look to each other. I know when I worked in a nursing home, many times I would pick up the phone and call a social worker at another facility, because we're always experiencing the same roadblocks. And when we come together, we're pretty resourceful to find ways to get around things. This isn't the first time that, I think our industry has faced the ebbs and flows of the political environment, and we always manage to advocate the best we can for the populations that we serve. And I'm sure that this time is not going to be any different. Thank you.
Thank you so much, Monique, for your overview, and we really appreciate getting even more specific around long-term care. Many of us have worked in long-term care, aspire to work in long-term care of all kinds, and so it's very important for us to, again, just think creatively about the opportunities for our skills to really shine in our advocacy work and partnering with the long-term care ombudsman, reminding ourselves that reaching out to the ombudsman office isn't a punitive act. It's an act for support and advocacy on behalf of our clients and residents and care. And it's hopefully could lead to, improvements and sort of getting the attention of administrators in long-term care facilities that is needed to make some swift and quick changes. So thank you so much for this. And again, just a reminder that I know I see some comments in the chat. We'll have opportunities to ask all of our panelists questions at the end. And with that, we are going to move on to our final speaker for today. EJ, let me just make sure I can spotlight you, or Dr. Greenfield is gonna Thanks, Dr. Greenfield. Okay, so we have EJ Busy, who's a licensed social worker, has the CALA designation, which EJ can speak to, and then is the director of senior programs at Brightside, and especially an alum of our program. So thank you so much.
Thank you, Lauren. And yes, absolutely a proud alum of the Aging and Health Certificate Program. I graduated in 2017. I am a licensed social worker and certified assisted living administrator. So with that, I serve as a director of senior programs at our nonprofit. Next slide. And so I work at the Brightside Family. It's actually where I interned in my second year of practicum placement. And so they had hired me on before I graduated. And I've been here for nearly a decade, which is kind of amazingly beautiful. But our nonprofit, we are kind of a group of nonprofits, and we provide affordable assisted housing, affordable housing, affordable assisted living, and support services responding to the changing needs and preferences of older adults. And so we do that through many venues. We have our flagship facility, which is our assisted living facility, Brightside Manor. But then we also have developed independent senior housing. So that's affordable housing for people. And we've gotten funding through both the federal government and the New Jersey HMFA. We also do a lot of community programs, so helping people in their houses, in their apartments, sometimes meeting community spaces. And what we're largely proud of is our community advocacy. So we have a couple different programs within our organization. Um, but by and large, so we're in the northern part of New Jersey. We serve mostly people in Bergen County. Many are on Medicaid and many are aging alone. So that is certainly a roadblock and a challenge to have to face because a lot of times you're working not with family systems when you're speaking to low and moderate income older adults, but the older adult themselves. And so making sure you convert things into lay terms. So next slide. Why this one big beautiful bill matters in everyday aging and practice. What I do want to first start with is we need to stay human and not legislative. Policy does show up in everyday life. It's not abstract by any means. And so, as you heard from my previous presenters, can someone stay in assisted living? Can they afford the food and medications when they're living out in the community? And when we say out in the community, that means in their home, their apartments. Maybe they're in a subsidized senior building, but usually they're in standalone houses. And can they understand the different mail that they're getting? Because as they're hearing things in the news, they're also receiving mails, they're receiving phone calls, they're hearing things at their senior center, and making sure that, what we do as social workers, we provide stability to help to allow them to age in place when possible. Brianna mentioned earlier that, federal bills, any bills really have ripple effects. And what I do want to emphasize is we don't need to know every provision to understand the directional risks that are happening to the people that we serve. And for aging services specifically, the biggest issue is the system strain and the complexity that it may be, as you heard from all of the data that my previous presenter said. So, aging well isn't just about healthcare, it's about whether the systems are stable enough for people to rely on. And so when the systems become harder to navigate, the older adults feel it first. They're the ones on a fixed income. They're the ones who had spent their entire lives believing that they had the government to fall back on. And so next slide. What to watch out for when working with people on Medicaid and in home and community-based services. That's what HCBS stands for. And so, of course, the changes in Medicaid funding. Galila talked about the increased administrative requirements, and so more frequent renewals equal more procedural terminations. Monique mentioned that one of the examples is Medicaid renewals used to happen annually, but it's being proposed to happen every 6 months. And so one of the more frustrating things is the mail delays that happen. And so by the time someone receives it from USPS, the due date is in 2 days instead of the 10 to 14 days it says on paper. And so it's always a scramble to have to fit it in that 2 days. Do you try to call and advocate for an extension or a grace period, or do you just try to make it happen before the due date because that's what they have on paper and you want to make sure you're not hitting those procedural roadblocks? Um, And, one of the largest issues is getting the bank statements because they ask for the look back, even for the initial application, it's a 5-year look back. So getting that, it takes time. We're going to take months to do this. But when you have 2 days and you need to get at least 3 to 4 bank statements, and not every older adult is doing online banking, making sure that they have the transportation to go to the bank. Are they able to do it themselves? Is there an authorized representative able to pick it up for them? So having to kind of navigate all of that. Um, but when someone is waiting months for MLTSS services and they do get the approval, Medicaid approval, even though it has already taken months, once you are approved, doesn't automatically mean that you get coverage as soon as possible. New Jersey is actually a managed care state, meaning once you're approved for Medicaid, you still need to be assigned to an insurance company. And so in New Jersey, that's Horizon, United Healthcare, Aetna, WellPoint, Fidelis Care. And so we have to make sure that people are understanding that though they got approved, sometimes they also still have to wait for the healthcare coverage until they got that health insurance enrollment. And so, you know, older adults, they don't experience policy changes, but they experience the uncertainty that is falling under that. And so, home and community-based services and the assisted living work that I do works best, obviously, when it's predictable. But frequent changes, paperwork, the funding uncertainty, it really undermines aging in place and allowing people that dignity to make the choice in how they want to age in their final chapters in life. So, home and community-based services, it shouldn't be just a budget line. It really is the difference between independence and isolation for an older adult. So even when the benefits remain, instability can cause harm and fear in someone. And like Brianna mentioned, whether that means going in person or having that advocate helping them out. We need to make sure that we kind of reduce and de-escalate any uncertainties that they're feeling. Next slide. And so MSPs is a Medicare savings program. So what I want to watch out for is Medicare savings programs and SNAP. These are often overlooked essential supports, and these benefits can really help make healthcare usable, not just available for people. Many older adults qualify for Medicare savings programs and SNAP, but don't realize how fragile that access can be. Like we've been saying over and over during this call, a missed letter or a confusing renewal can really undo years of stability that they had had. And so a loss of benefits due to paperwork or renewals, confusing about notices, changing in statuses. But what is really scary is that quiet disengagement. When people stop asking for help, when it's just overwhelming and they kind of just step back from it. Um, and so, there have been with the OBBA several finalized rules that would have expanded access to Medicare savings programs, but those were blocked or delayed under this law, meaning people that were going to be automatically qualified for these Medicare premiums and cost sharing discounts are not going to be anymore. And so it would be on their onus to have to know that they're eligible and then apply for it rather than systemically they can see that people are eligible for it, but they're not automatically qualifying them anymore. And so that's a frustrating feeling as, an advocate and a supporter for older adults. And then for dual eligible older adults, I know that Glila mentioned that at least for the workplace expansion of Medicaid, that some of what she was talking about wasn't um, eligible or wasn't relevant to what that changes were. But for some dual eligible older adults, so that's people who qualify both for Medicare and Medicaid, the cuts and changes could mean more cost sharing, like she had said, the administrative barriers, and really increase that out-of-pocket cost for them. And of course, with SNAP, they may have a reduction in their eligibility, and so it affects their food security for low-income older adults. There are some people who had gotten used to receiving maybe about 200 in their accounts, and now they're getting the state minimum, which is currently 95, which I do have to give New Jersey credit for because the federal limit is $50, and thank goodness New Jersey at least bumps us up to nearly double at 95. And let's hope that our state legislation can continue keeping up better than what the federal eligibilities are. But with that, we want to empower their voices and not silence them. We want to make sure that older adults feel that they can speak up. Um, but I also want to make sure that you, as social workers, feel that you can speak up. And so, next slide. We are the human capital investment. We can be the navigators for older adults to have a live person who's trained to not only hear what a senior is saying, but to truly understand what the question or concern is between the lines is really key to serving their true needs. In essence, we are the interpreters for the under-enrolled benefits and entitlements, and humans can really help translate. We are those translators. We can turn those into lay terms, into human terms because social workers, whether you're macro, meso, or micro, you are noticing the patterns, whether, maybe you're hearing it with your actual clients or you're seeing it on the papers and the reports you're doing, or you're talking with your coworkers or if you're overseeing social workers, indirectly through your team. And so we protect the continuity and not just the access to it. And, one of my favorite things about social work is that we're ever evolving. If someone wanted to do micro and counseling only, you could have been a psychologist, but you picked social work. You wanted to see the bigger picture. You wanted to kind of see more about the human perspective. And so remember that decision. You picked it for a reason. Um, we are often the only people that are helping them to interpret. Our advocacy is often quiet, but it is deeply impactful. And even if you are a clinical social worker or you decided not to do management and policy or you decided not to go macro, you still are allowed to go testify as a provider at state or local county hearings. So use your voice with that experience. You're speaking for their lived experience. And so policies can change, but our role as stabilizers remains strong as ever. We may not write the policy, but we shape how it's lived by our constituents. And so, if there's one thing I hope that we carry forward, it's this: that aging policy is ultimately about dignity, independence, choice, and integrity. And our work, whether it's in assisted living, housing, the community, in advocacy, helps people feel anchored in the systems that are shifting beneath them. And how we help them is by keeping up with these systems, understanding legislation as it's proposed or as it's passed. And really, that's what matters most, helping people to realize how it's going to affect them, and then us beating that system to the punch. How can we work around it and make sure that our constituents are getting what they need to live their best life? So then next slide is contact information if you want to talk with me, but I think Lauren's going to open it up to Q&A for everyone, so I will stop talking now.
Thank you so much, EJ. What a wonderful way to round out the conversation, really encouraging us to stay true to our social work profession and ethics and guidelines. And I just thank you all for what a wonderful presentations from all of our wonderful panel. I wonder if, yeah, I'm actually going to thank you all again. I'm going to go ahead and stop our recording. We won't record the Q&A portion so that students especially and professionals on the call feel comfortable if there's any more specific questions. So I'm going to go ahead and stop the recording now.